So I think what you need to realize is the entity of macular edema, which is something that requires treatment. So you can just tell them in brief about that.
Okay, now we are going esoteric. Macular edema essentially can be divided into two broad headings. One is cystoid macular edema, production of cysts in the macular zone. As you are aware, the macula is a part of the retina which is most important as far as vision is concerned. And the second, of course, is diabetic maculopathy or diabetic macular edema. Now, in the standard, what we call cystoid macular edema, most frequent causes, of course, are the presence of exposure to excess ultraviolet light, the presence of branch retinal vein obstruction or a CRV or central retinal vein obstruction. And as far as diabetic retinopathy is concerned, diabetes is the main cause for it. Unfortunately, even following the regular cataract surgery, you tend to get a macular edema, what we call the Irving gas syndrome, where it tends to supervene normally a month or a month and a half or 2 months follow. Which is one reason why we now, as a regular routine, or most ophthalmic surgeons, a regular routine, following a cataract surgery, use either bromfenac or levofenac eye drops for a period of 18 to 20 days to prevent it from occurring. But macular edema is the cause for the fall in vision. Now, if you can control the edema, then life is great. One of the easy ways of assessing the edema is to utilize a thing known as a Fourier OCT. OCT is nothing much more than an optical coherence tomographer, which simple language is like a CT scan of the retina. It tells you the density and the thickness which has been affected, which causes macular edema. Normal range of thickness of the macula is anywhere between 180 to 220, 240 microns. Anything more than that comes into the realm of edema. But once you assess it, then the utilization of drops usually is adequate. For diabetic macular edema, try and understand that 90% of fall in vision which occurs in diabetes occurs because of macular edema. Macular edema in the earlier stages is, if I can just go on for a few seconds, tends to occur when the earliest signs are a person says, I can read but I'm not reading too well. I can see but my vision is a little misty. In a diabetic, it's the first sign of diabetic maculopathy commencing, which means that he needs to go and have himself assessed. Diabetic maculopathy, once it starts and advances, can be controlled utilizing various anti-VEGF drugs and drops and injections, but it will lead to a progressive fall in vision. So the important thing is to try and detect it at its earliest. Now, with all edemas and macular edemas are nothing much more than a collection of protein-based liquid which tends to accumulate in the macular layers. What we need to do essentially is to try and get them out as soon as possible. Which leads us into another most important cause of macular changes, which essentially is drug-based or drug-induced. A number of drugs can induce macular changes, especially some of the malaria-based drugs, some of the drugs which are utilized especially for chemotherapy tend to precipitate a lot of them. So we do need to keep that along the side and look into it. But the moment you find fall in vision for no unexplainable reason, the eye should be evaluated in detail.
So nowadays, we are all, as ofthals, aware, but as a family doctor, you all should be aware that there is a treatment line known as intravitreal injections, which are given to treat such disorders. So you may have a patient coming back to you and say, my doctor has advised me to do one of the following three, and they are actually different costs. So I'll just name them. It's Avastin, Macugen, and Lucentis. If you can just tell the ground.
Basically, they are for the treatment of what we call as age-related macular degeneration. I know I'm standing between you and food. Quickly divide that. Age-related macular degeneration essentially can be divided into two categories, dry and wet. In dry, there's formation of what we call as drusen, which is nothing much more than collagenous matter which tends to accumulate in the macular zone. Or the alternate is a wet macular edema where there is exudation which collects in the central macular zone in the formation of cysts. Now, dry macular degeneration is not amenable to treatment, which is the one reason why we try to evaluate life. That is the reason why when you go to an eye doctor and your vision falls and he says AR20, he tells you, first do angiography, then bath mein bath karo. Because he wants to know whether it leaks. If it leaks, you treat. If it doesn't leak, usually you cannot treat. Though there is now a grey line where a number of dry cases become wet, and wet on the other hand after a period of time tend to lead into fibrosis and become dry, leaving the grey areas. Now the easiest way of treating wet age-related macular degeneration is the anti-VEGF group of drugs which have now come off the names which he said. In other words, I'll say the three common names which we utilize in bias as Avastin, Lucentis and Macugen. And these are the ones patients will come back to you and ask you as general practitioners which can I use and which is useful to me, because the doctors are getting confused, which is what often happens. Remember that Avastin and Lucentis, which are both anti-VEGF, essentially cut down on formation of new blood vessels. Now, when we go to wet degeneration, it is the formation of new blood vessels from the choroid growing into the retina. If we can block those blood vessels, then life is good. And anti-VEGF, which essentially are the group of drugs which help us doing that. Avastin was originally a drug which was made by a company known as Genentech and was used for colonic cancer. It is also accepted by FDA for treatment of breast cancer and for small cell lung cancer. But it works by choking of blood vessels, and we found that it works in the eye. Rather than flooding the system with a large dose of Avastin, because Avastin has a number of side effects, we found that just giving a very micro dose in the eye works well, which is where the intravitreal injections came about. Genentech then decided that if it works, then why don't we make a new drug? So they developed a drug which they called as Lucentis. And Lucentis essentially is a purified FAB radical of Avastin, and it's supposed to be a smaller size radical and it's supposed to be more effective on the macula. Unfortunately, the trials, and at present there's still a major trial in American Academy which is going on, have shown no significant difference between the two drugs. Cost difference is tremendous. Lucentis costs you in the range of 40 to 50,000, while Avastin costs you about 1,000 rupees, or 2,000 or 3,000 rupees. So the range of cost is tremendous. Avastin comes in a vial of 3 ml, you need to give 0.1 or 0.2, so an average doctor can get about 10 to 15 doses out of a vial. While Lucentis single dose vial, you have to give double amount. On the other hand came about another alternate which is known as Macugen, which came and went. Macugen works well, but it needs to be combined with PDT, which is photodynamic therapy, which is also utilized at the same time. Now the big problem with all these anti-VEGF line of drugs is that you need to give them repeatedly if you have to have any effect. There are a series of trials, we won't talk about them all with very nice names, but to make it short, if you want the quality of vision to be maintained, you need to get the injection every 2 months. Recommended dose is every 6 weeks, but 2 months is still that time. And you need to use it for a minimum period of a year to 18 months for it to have an effect. So when you start giving the injection, you have to tell the patient that, look, taking for 2 and stopping is not going to help you. When you take it all the way down, and you have to be prepared for it. Admittedly, it doesn't pain. It's almost a painless injection. Still, it is given in an operation theater. There are risks as far as it is concerned. There is a risk of getting an infection from getting the injection. If you don't take it in full sterile facilities, there is a risk of a detachment developing. There are limited risks to Avastin and Lucentis. It has been reported that they cause, Avastin can cause myocardial infarction. It has also been coupled with stroke. But considering the fact that in a city like Bombay, per day I am sure at least 500 injections are being given, the problems you see are very, very, very few indeed. And considering the fact that it is the only line of treatment available to us, I think it's something which needs to be done. If you can afford it, Lucentis, sure. Many reports saying Lucentis actually gives a little better result than Avastin. But in case your patient cannot afford it, mind you, you're talking of the full year's quota, not a single injection, then Avastin is an option which can be exercised. But Genentech has not accepted it, even though the American Academy of Ophthalmology has accepted it as a routine method, though FDA has.